Welcome all and a very good evening to all. Welcome all dear executive members, CIP members, delegates and speakers. Today's topic of Maha Mentor Mentees of this Maha IP session is treatable pediatric neurology in office practice. Myself, Dr. Sonali Shirbhate, co-chairperson Women's Committee Maha IP, and my co-host Dr. Reena Rathi from Nashik. We are the moderators for today's sessions. So I welcome our president, Dr. Hemant Gangulia sir, our secretary, Dr. Amol Pawar sir, our EB member, Dr. Jay Bhandarkar sir, he is convener, our guest of honor, Dr. Anaita Hegde madam, our all she is mentor, and welcome all our mentees, Dr. Prashant Utage sir, Dr. Umesh Kalane sir, and Dr. Madhavi Shedke madam. I also welcome Dr. Renu Boralkan madam, Chairperson Women's Committee Maha IP. I welcome on behalf of Maha IP to all of you. So today's session has been granted 1 MMC credit point. So dear all delegates, please don't forget to put your CIP number and your MMC number in the chat box. And don't forget to subscribe YouTube channel of Maha IP. So moving further to the program. Because of our tomorrow's EB meet, our president and secretary are in traveling. So I would request Dr. Jay Bhandarkar sir to join today's session, and I will request him to speak few words about this program of Maha IP, Maha Mentor Mentees.
Thank you, Dr. Sonali. At the outset, I good evening all of you for this very important session on neurology. This is mentor and mentees. So I think Madam Anaita Hegde is mentor, and all three are this Dr. Madhvi, Dr. Umesh, and Dr. Third person is all mentees, and I think all other are the mentees in the position, because in our busy OPD, and when you more of a take care of more of the infective conditions in our pediatric OPD, and when we came across some neurology condition, we stuck up, or we have very less time to look after that patient. So I'm very confident this today's session going to get a very good I think tips of how to diagnose on urgent basis this neurology condition and refer back to our neurology friends. So all on the half of Maha IP, again welcome all on this dais, and again hand over this dais to Dr. Sonali for further proceeding. Thank you.
Thank you, sir. Now I would request our gorgeous guest of honor, Dr. Anaita Hegde madam, to speak few words about this Maha IP Maha Mentor Mentees.
Good evening, everybody. Firstly, thank you very much. I am humbled and honored to be invited on this platform. Thank you, Doctor. Thank you to Dr. Hemant Gangulia, Amol Pawar for organizing, coordinating. Thanks to Sonali and Reena for moderating this session. And thanks to my three mentees who are going to do a great job today in highlighting very important aspects of cases that we all see in practice, and we should make a point not to ever miss a few flags or red flags for everyday office practice. As a mentor, it is a real proud moment. That is nothing more satisfying and gratifying than to be invited to be part of a program with your mentees. I thank Maharashtra IIP for creating this program. I think it's a lovely program, and it's a great way to bring cases and students and teachers together. So thank you for this excellent program, and I look forward to very active participation from the audience. Please put your questions in the chat, because this is what this program is for you to ask your questions so that we can help you and guide you how we reached our diagnosis. Thank you.
Thank you, madam. As I told earlier, this session has been granted 1 MMC credit point. So I would request our MMC observer, I would welcome them, Dr. Purushottam Devi from Nashik and Dr. Sachin Vahadane from Ahmednagar. I welcome them. I would request Dr. Purushottam Devi to speak few words about this program. Dr. Purushottam Devi, sir. Hello.
Ma'am, sir is going to join at 9:15.
Okay, madam. So moving towards the session, the CV of our mentor, Dr. Anaita Hegde madam is too much, but I would like to speak a few words about her CV. Dr. Anaita ma'am is consultant pediatric neurologist at SRCC Narayan Healthcare Child Hospital. She is director of neurosciences at SRCC Narayan Health Hospital. She is honorary at Jaslok Hospital and Wadia Hospital, Mumbai. She is president of AOCN, Association of Child Neurologists, India. She is EB of International Child Neurology Association. She is founding member of Child Neurology a group from Mumbai and Rural Child Neurology Program, Maharashtra. So I welcome Dr. Anaita Hegde madam. The different cases of the treatable pediatric neurology in office practice will be discussed by our mentees. So introducing our mentees to you, neurological conditions in children represent proportion of global burden of diseases. They contribute to premature mortality and years lived with disability. So let us know further about this from our first mentee, Dr. Prashant Utage sir. He is from Hyderabad. He is pediatric neurologist, Hyderabad. He is consultant at Utage Child Development Center, Hyderabad. He is guest faculty at NIMH. He is DNB trainer at Hyderabad. He is fellow pediatric neurology at Wadia Hospital, Mumbai. He has published various case reports. He is secretary of Child Neurology Group, Hyderabad. He is CEO, founder of Umang Institute of Autism and Disability, and he is EB at Associate Child Neurology. So I welcome Dr. Prashant Utage sir for further proceedings.
Thank you, Sonali ma'am, for a kind introduction. I'm very much thankful to Dr. Hemant sir, Maha IAP president, and Dr. Amol Pawar. When we met at Aurangabad, he shared that this kind of program and we want to invite. Then immediately, it's honor that Anaita ma'am agreed to be, in spite of her busy schedule, she agreed to be a part of this program. And thank you, ma'am, for accepting invitation. Thank you, Sonali ma'am and Rati ma'am, to introduce me. Shall I share my screen?
Yes, sir. Yes.
Yeah, I'm very happy that this session, when someone says neurology means nothing much can be done, but the theme which we started with the suggestion of our Guru, Dr. Anaita ma'am, it was that let us give a positive vibe about the pediatric neurology. So here I'm presenting my first case. She's actually a 1 year, 9-month-old female child, born to third-degree consanguineous marriage, and her antenatal natal history was uneventful. She cried immediately after birth, no complication. Her developmental history in terms of gross motor, she has achieved neck holding by 3 months, sitting with support at 7 months, standing with support by 10 months, and walking with support by 14 months. Fine motor, we assess on the history, it was age appropriate. Language also age appropriate, and she was talking around 5 to 10 words at the time when we took the history, and the cognition also looks age appropriate. Now, this child actually came to us for the rehabilitation. Her first complaint that there is a short febrile illness and followed by child was altered sensorium, drowsy, irritability, and there is a significant proportion of gross motor regression. And this has happened at the age of 15 months of the age. With this episode, child has received treatment as per the pediatric protocol. Child improved over the period of time of 4 months. She improved in terms of cognition. Her drowsiness has come down, irritability has subsided, and child cognition was better. There was still some lag in the regression in motor milestones, but recovered. Again, she has faced the second episode of regression, similar episode by short febrile illness, then altered sensorium, drowsiness, and then encephalopathy features, and then child presented with left with gross motor regression mainly, and she has recovered with rest of the things. Now at present, when she presented to us, she was unable to walk, was sitting with support, and there are no history of associated seizures, no history of breathing difficulty. There is no history of any abnormal movement on the history itself. And this is the video of the child. This was before, she presented to us. She is even in a sitting posture, you can see without support, she is unable to sit. So what should be the...
1 second, Prashant. Yeah, keep going. So at the end of this, what you see out here, from this history, though she's come to you at the end of the entire history, what are the things running through your mind and how did you come to these thoughts?
Ma'am, as antenatal and natal history is like uneventful, and the one point in the history is it is a third-degree consanguineous marriage. Then 2 episodes of regression, which has presented after the short febrile illness, followed by encephalopathy and then regression, recovered, and again second episode after 4 months. So something which is pointing towards infectious and then causing these episodes. So something looking towards familial things or neurometabolic kind of things I am thinking of.
So you think that febrile illness was significant or it was just incidental?
This episode was significant febrile, but it was not significant to cause the encephalopathy. It was short febrile illness, 101 temperature, and then she regressed.
So if you're thinking of a febrile illness followed by a regression or an encephalopathic picture, so non-specific febrile followed by relative regression, motor, cognitive, whatever, what are the first things that are what are your first things you're thinking of?
Anything which triggers with the infection or short febrile illness, obviously, if I'm sitting in a OP, first will be the mitochondrial disorders usually we think of, which is triggered by the any infection, even it is not significant.
So mitochondrial would be first on your cards?
Yeah.
I mean, when you're saying metabolic, there's no skin lesions, there's no hair abnormalities, there's no foul smell, there's no acidosis. So those things go a little against metabolic and maybe a little more on the mitochondrial front.
Yeah, one of the diagnoses, but this is at the end of the history where we see it is more in favor of a mitochondrial. Now, when we go for the diagnostic test, I think it will be more clear. This is at the end of history, looks like a mitochondrial, and then metabolic when we go for the, obviously there are no neurocutaneous markers or obvious dysmorphism or pointing towards any particular neurogenetic or neuroregressive disorder.
Okay, carry on.
Even there were no coarse phases, so again, storage disorder, little bit we can rule out.
Yeah, so no hepatosplenomegaly, no ophthal abnormalities, no skin lesions, all that to rule out neurodegeneratives. Okay, go on.
Yeah, so these are the differential diagnoses I thought of, and then we move towards the examination. This baby, yeah.
Just one second, go back to the picture. She looks pretty good, right?
This is
fixing, tracking. Look at her face. She looks pretty alert, pretty active. Otherwise, looks pretty good.
This is yesterday's picture.
Nice. She's doing really well. Okay.
And this is previous picture and video also you have seen.
Okay. Let's go on. Let's go on.
So this child, this baby was alert, cognitive wise very good. Eye contact was good, recognizing the parents. Her higher mental functions were looking quite normal. And it is a normocephaly. AF was closed. There is no external ophthalmoplegia or any squint observed. Then speech looks normal, vocabulary of few words. There is some kind of hypotonia observed, and while walking or taking looking like few ataxic features on the examination. And child is not able to stand on her own, not able to walk without support. Power was 3/5 in the lower limb. Reflexes were preserved, normal DTRs and superficial plantars were equivocal. Rest of the things like sensory examination was normal. In lower limb, as the history was not suggestive of any dystonia, but on examination, I could find there is some kind of dystonia in the especially lower limb. There is no history of any irregular respiration and no organomegaly or any neurocutaneous marker on examination. So shall I move towards the investigation, ma'am?
Yeah, go on.
So with this, keep in mind, we investigated for the routine CBC and CRP to rule out whether this is a significant infection or not. And routine random blood sugar, serum electrolytes were normal, which were not causing any kind of encephalopathy like hyponatremia. Serum calcium, vitamin D3 and B12 were normal. Thyroid profile done, just to take a chance. Already they got it done and then came to me. But serum lactate, we did it thinking of mitochondrial. So serum lactate was 16, which is a normal for that lab. CSF routine and microscopy already done, and lactate also done, which was not showing any particular pointers towards any mitochondrial. Serum ammonia for the metabolic, which was not showing great elevation. It is 22, which is of hardly 2 digit more than the normal level for that lab. Here they got the EEG done, which was showing normal study. NCS already done and then came to me, so it was showing normal, no other things. To rule out metabolic things, we send a Tanama spectroscopy and GCMS, which were not diagnostic or pointing towards any particular disorder or metabolic disorders. Viral markers already sent during the admission, which were showing the negative study.
So before you go on, Prashant, just go back to the previous slide, the lactate. You're telling me you're suspecting mitochondrial and your CSF lactate and blood lactate are both normal. Does that give you any clue? Does that help you in any way?
Yeah, ma'am, it is pointing towards on history, we were thinking of the mitochondrial. So these things little bit against that point, like against our expected diagnosis.
No, but when did you do your sampling? Your sampling you did when the child came to you at the rehab phase after she had recovered from both the episodes.
Yes.
So is the timing of the sampling important?
Yeah, obviously in a critical samples, as we see, it is important.
Absolutely. So a negative lactate does not rule out mitochondrial. A negative CSF lactate does not rule out mitochondrial. A positive lactate has numerous false positives also, like sepsis, infection, necrosis, any of that. But it is a clue. So if it were positive, it would have been more helpful. And it should ideally have been positive in the acute sample or the critical sample, but a negative one does not rule out that this could be mitochondrial. So I would still keep mitochondrial on the cards.
Yeah, true, ma'am. So sampling is critical, as you suggested, and definitely negative lactate or normal lactate doesn't rule out the mitochondria completely.
Okay, go on.
So now this is the typical MRI, because obviously being a neuro, once they approach, we went ahead and did the MRI. And MRI, if you see, there is an extensive bilateral symmetrical involvement of the basal ganglia. Here you can see putamen, globus pallidus. Even there are cystic changes. It is extensively involving the infratentorial structures, cerebellum. This is a cystic lesion, T2 hyperintensities. So this picture itself showing we can say sometimes bat wing appearance on the MRI.
So what are you thinking on this MRI? What does it indicate?
In this, if you see acute necrotizing encephalopathy, also one of the differential diagnoses. Sometimes
Acute necrotizing would be more thalamic.
yeah, more thalamic, but one of the differential before because this MRI has been reported as a infectious cause. They have not reported it is a metabolic, but after seeing the MRI, it is more in favor of mitochondrial or
No, but you're saying metabolic. Why are you thinking metabolic? What is it? Just explain to everyone what is it on the MRI that makes you think this is metabolic?
it's more of a bilateral symmetrical basal ganglia involvement. There is extensive involvement in the infratentorial structure like cerebellum hyperintensities are there. There are cystic lesions which are more in favor of metabolic or mitochondria.
Okay, so bilateral, particularly basal ganglia.
Yes.
So when you get bilateral basal ganglia with cerebellum, with midbrain, with brainstem, those are the characteristic features which make you think that this could be a metabolic for sure, but mitochondrial metabolic disorders, because this is where energy metabolism is at its maximum. Okay, let's go on.
So with this clue, like she has received the IV fluids, antibiotic at the time of febrile illness. Then when they shifted, as in, we started with mitochondrial cocktail regime. I'll go into the details of what we have started. Then there was as I mentioned, there was a dystonia. So started with trihexyphenidyl. Child started with physiotherapy and occupational therapy. The picture which I have shown when they were in a rehab for the physiotherapy. So this is overall the mitochondrial cocktail regime. Usually we start with coenzyme Q, and the dose is usually 2 to 8 milligram per kg, daily divided into 2 doses. Like brand name we use sometimes if syrup formulation Nutriel which contains carnitine as well as coenzyme Q, or coquine 30 milligram tablet is available. This is just for the practical purpose I'm telling. Then riboflavin, it is available in a 10 milligram strength, and the usual dose is 50 to 400 milligram per day. Then L-arginine, L-carnitine, vitamin E, vitamin C, folinic acid, thiamine, and these are the cocktail regime what we started for this child. And physiotherapy. Now this child just is a video. You can see this child is able to walk after starting this.
Now, given that MRI was so bad with bilateral basal ganglia, cerebellum, etc., is there any mitochondrial that when you treat it, the recovery is so good?
To be frank, ma'am, in this child, child improved, but not up to the mark. This video is of just 2 days back when we started particular targeted therapy, but mitochondrial cocktail, child started improving, but child was unable to walk, just improving day by day, but was not able to walk. But definitely mitochondrial, they beautifully respond to the mitochondrial cocktail regime. And that too during the acute febrile illness or a stress period in a high dosage, it gives a more improvement. Drastically.
And how often, in all these years, how often do you see children who recover on the mitochondrial cocktail?
For us, obviously,
we put it on so many patients, and what percentage are supposed to respond or to do well on it? It's usually less than 10%. Less than 10% response. So that is really a clue to you as to what this could be, because she responded so beautifully. Because this is very good for that MRI picture to have started walking and to have cognitively looking so good. You've got very good response to your mitochondrial cocktail.
Yeah, ma'am.
So that
actually, this child has been counseled that don't do anything, just keep it at home. Someone, our old patient, referred for the rehabilitation. Then we investigated and obviously started with the regimen. There is a beautiful response.
Okay, go on. Let's see the rest.
So then after this, thinking of good response, we sent the whole exon sequencing with mitochondrial genes, and this is the result for the whole exon sequencing. So this is the SLC 19A3 mutation that is on location exon 2. And it has turned out to be thymine metabolism dysfunction syndrome 2, that is biotin or thymine responsive encephalopathy type 2. And this is the gene where there is a transporter deficiency will be there because of the mutation. So this was the likely pathogenic variant. We got it. And when we started with treatment, child responded again in a drastic way. After she improved with the mitochondrial cocktail regime, as you mentioned, less than 10%. But this has turned out to be something different, which was not even I was expecting in this case. And I was very, very happy before sending. Usually we think what we are going to do by spending such amount of money. And they were very reluctant why to send. I said there are a few things which can be treatable. And luckily, this has turn out to be a treatable entity. And being a pediatric neuro, always we are happy if we have something to give to the parent, hope and permanent treatment for them. So this is a thymine metabolism dysfunction syndrome 2. It's an autosomal recessive metabolic disorder. It is characterized by episodic encephalopathy, which we have in this child. And it is obviously usually triggered by the febrile illness. It is a short period. And they presented with altered sensorium, confusion. Few cases they have the seizures, sometimes external ophthalmoplegia, dysphagia, dystonia, and they may presented with myoclonic epilepsy also. Then sometimes if it is not treated properly, then may lead to the coma and death. This child has been, as I said, started with biotin, and the dose was around 5 milligram per kg per day. Thymine, this child, we have started with 10 milligram per kg per day, and we have gone up to 30 milligram per kg per day. That with the tablet preparation. And then she started walking drastically after starting the high dose of biotin and thymine. And then family has been counseled for the same, that it is a lifelong treatment. And this is definitely during the stress, we need to give high amount of these thymine and biotin. So we're very happy to counsel the parents that it is a treatable condition where if she takes the medicine like simple vitamins, she will be able to recover from this. And in this case, there is no much damage happened. So in summary, or we can say take home message, there is a reduction in the cost of mitochondrial or a whole genetic sequencing or genetic testing last 2 decades. I remember when in Vadia we used to think we had to send it to the Australia, and for the whole exon sequencing it was too costly and cumbersome things, but now it is easily available, so we should utilize that. And the importance of clinician and the laboratory reporting genetic counselor is very important to communicate with each other, because many times we may get the variants of unknown certain significance. And early diagnosis in such type of treatable genetic condition is very important, so that we can prevent one child from becoming a cerebral palsy, or we can prevent them from going to coma, or sometimes rarely it may lead to death also. And definitely counseling of the parents, genetic counseling for the next baby. And in this case, prognosis is good if you give this 2 vitamins lifelong, and prenatal diagnosis very, very important in this case.
So I would like to highlight here, I think the real take homes are that if you have third degree consanguineous marriage was a warning that made you think metabolic higher on your list. When a non-specific febrile illness gives you an acute regression which is out of proportion to the fever or to the infection, it should register on you that you might be looking at a neurometabolic disorder. Thiamine biotin is one of the treatable ones. It's also a mitochondrial disorder. It works on the same mitochondrial pathway, and that is why you got the characteristic basal ganglia, cerebellum, midbrain, brainstem pathologies which were there. The takeaway on thiamine is they present with encephalopathy. So very often after an infection, you'll get regression, you'll get myoclonic seizures, you might get ptosis, sighing respiration, ataxia, hypotonia. Those are all the mitochondrial features. But in thiamine metabolism, they typically come encephalopathic. But the minute you put them on thiamine, and that's what saved this child, was the mitochondrial cocktail, which you put as a broad spectrum cover, actually made all the difference. So they recover really well. They come out very well. They need thiamine more than they need biotin, but they need very good thiamine. So when we are in doubt, riboflavin, biotin, leucovorin and thiamine. These are the 4 vitamins that you should put on every child until you get your genetic report. Why? These are treatable metabolic disorders, and not only are they treatable, they come out with excellent results if treated early on. So however good the genetics is, and now however cheap it is, it still takes a month to 6 weeks for that report to come back. We don't have the luxury of time for that. So give the mitochondrial cocktail, wait for 2 to 3 months to see the benefit. He's right, only 10% of them will actually benefit, but if you fall in that 10%, you can make a difference in that child's life. So this was one of those metabolics that you would have otherwise thought you can't treat, but came out with brilliant results because of timely treatment with thiamine supplement, either injectable, oral, whatever is available. So that was a treatable one that I think we should not miss in office practice.
Thank you very much, madam. Thank you, our mentee, sir, for discussing such a treatable neurological case which responded to mitochondrial cocktail regime. And really, the early diagnosis and genetic tests are both important for the total treatment of these disorders. I would like to thank our, thank you, madam, Anaita madam, and thank you, Utage sir. I would like to thank our MMC observer, Dr. Purushottam Devi sir from Nashik, and Dr. Sachin Vahadane sir from Ahmednagar. Are you present, Dr. Sachin sir? Would you like to speak? I welcome you. Sir, please unmute yourself.
Hello,
Yes, sir.
I'm Dr. Sachin Vahadne. I'm MMC observer. I'm a pediatrician, associate professor of pediatrics at VK Patil Medical College here. And it was a nice lecture, and all the participants gave excellent insight into the topic. Thank you.
Thank you very much, sir. Dr. Devi sir, are you there? Dr. Devi sir, I welcome you, Dr. Devi sir.
Sir, kindly unmute.
Yes, I am here. Good evening, respected Anaita madam and all. This under the Maha under the leadership of Dr. Gangolia and Dr. Amol Pawar has taken commendable initiative in refreshing the knowledge of all practicing pediatricians in a simplified manner. Today's topic is also important one in our office practice, and I hope all of us will be benefited by this academic fees. Thank you all, and IMA for inviting me as an observer. Thank you.
Thank you very much, sir. Moving further, I would request Dr. Reena madam to hand over. I will hand over mic to her for further proceedings.
Thank you. Thank you very much, Sonali ma'am. Before going to our next mentee, I would like to welcome our Secretary Maharashtra IIP, Dr. Amol Pawar sir. He is with us. So will you like to have a few lines with us? Dr. Amol sir. Sir, kindly unmute yourself. So you are still mute.
Thank you, Reena. Thank you, Reena, for your kind words. I welcome, on behalf of Maha, I welcome Anaita ma'am and Dr. Prashant Udge, Dr. Umesh Kalane sir, then Dr. Madhvi Shelke madam, that they immediately agreed for on Maha's first call to be there on Maha Mentor Mentees this episode. This is the 5th episode in a row, and we'll be covering all the subspecialties and will be giving justice to all the mentor and their mentees too. I thank moderators Sonali Shirbate ma'am and Reena also, and today's MMC observer Sachin Wadne sir and Devi sir also. All the best for this session. Thank you.
Thank you. Thank you very much, Dr. Amol sir. Good evening, everyone. Moving towards next mentee. Our second mentee for today's session is very well-known pediatric neurologist and epileptologist from Pune, Dr. Umesh Kalane sir. Sir is practicing at Dinanath Mangeshkar Hospital, BJ Medical College and Sassoon Hospital, and also at Bharati Vidyapit Medical College, Pune. Sir has achieved gold medal in DNB Pediatrics, fellowship through Global Health Program in Pediatric Neurology at Los Angeles, USA. Sir is certified electroencephalographer. Sir has published more than 20 papers at national and international level and peer-reviewed journals. Sir has presented many papers at national and international conferences too. Besides that, I am very happy to share, Sir is our senior from Pravara Medical College. Welcome to you, sir, and over to you. Thank you very much.
Thank you, Dr. Reena, for the kind word. And it's pleasure to be here with our mentor, Dr. Anaita Madam. And I'm very much grateful to Maha IP, Dr. Gangolia, Dr. Amol Pawar, and all the Maha IP team for giving me this opportunity and important topic for the pediatric neurology, as Prashant has already mentioned, that many times we think that it is not treatable. So we have tried to cover a few conditions where it is definitely treatable, and that should not be missed in the pediatric office practice. So with your kind permission, I will start presenting this case. So this is an unusual treatable cause of cerebral palsy, and when CP is not a true CP. So in a single slide, as we all know that cerebral palsy is defined, it is a heterogeneous group of various conditions, non-progressive disorders of movement and postures, which causes activity limitations with disturbances that occur because of the injury to the developing fetal or infant brain. And it is quite common in our country. The prevalence is almost 2 to 3 per 1,000 live births, and we all know various causes like prematurity, asphyxia, infection, intrapartum trauma, hemorrhage, or encephalitis. And there is no definitive treatment for the cerebral palsy, but supportive treatment, and hence it should be prevented, and we should seek few treatable causes of cerebral palsy, which are called as CP mimics. So I will start with this case. This is a very interesting case, a 10-year-old boy. It was presented to me 5 years back at the age of 10 years. And he was presented for abnormal gait, which is worsening since last few years with frequent falls. And according to mother, he was delayed from the beginning. He was never able to jump. It was a second by birth ordered child with no family history, no significant family history. No one in the family was affected. Non-consanguineous marriage. Otherwise, his birth history was normal. He was treated with physiotherapy. There was not much improvement. He was labeled as the cerebral palsy by various clinicians, diplegic cerebral palsy, and he came to us for the second opinion. So I'll just play the video here, just to highlight how he's walking. So the way he's walking, one can see definitely it's a spastic gait. He's not able to jump. His limbs are very much spastic. See the gait, but he's able to walk. So he was labeled as spastic diplegic cerebral palsy. He's following all my commands very well. So his cognition is very well maintained. There is no abnormal movements in the form of dyskinesia. Speech is absolutely normal. So,
Umesh, just 1 second. Sorry.
Yes, madam.
Before you share screen, if you put at the bottom clarity of video, because the video is not showing clearly.
Okay, madam.
Just stop sharing for 2 minutes. Go back. When you say share screen, now do share screen. And before you share it, there'll be 2 things at the bottom on the left-hand side. 2 boxes.
Yes, madam. Share sound and optimize for video clip.
That's right. Just tick them both.
Yes, madam.
So your
Thank
video
you.
comes clearly.
Okay.
ये परत
Is it okay, madam?
Yeah, it's a little
तर तिथे
better.
माझ्याकडे वळ आणि शीला बसत असं.
So he has difficulty in walking, diplegic gait, and on further inquiring about the history, mother refused that the child had any problem at the time of birth. It was a full-term antenatally registered delivery, vaginal delivery, carried immediately after birth. There was no feeding issue on the first day. So definitely there was no evidence of neonatal encephalopathy or insult on the first day. Child was discharged immediately on the second day from the hospital. His speech cognition was normal from the beginning. As I already mentioned, there was no family history, no major illness, no trauma. He did not have any bowel bladder issues. And despite therapy, according to mother, she noticed that there is worsening of the gait. Also, on asking further, she mentioned that at times she has noticed fluctuation in the weakness. And sometimes the child is little better in the morning hours or in the early part of the afternoon, and then worsening in the evening. So to show this video, the reflex is very brisk, almost flying. Significant spasticity, the lower limbs. So with this history, as I have already mentioned that it was diagnosed as cerebral palsy, but sometimes we have to think apart from cerebral palsy, other differences, particularly if there is no family history. So sometimes this kind of presentation can be there in hereditary spastic paraplegias, particularly with brisk reflexes. And one important finding in this video was that he was never laughing. His face was almost like an emotionless face. And there was paucity of movements. The way he was walking, there was difficulty in the initiating the movement. So some kind of extrapyramidal symptoms like Parkinsonism-like symptoms were there. So with this, our differentials were whether it is a hereditary spastic paraplegia, whether it is some kind of neurodegenerative disorders, particularly this neuronal brain ion accumulation or PCAN spectrum, where there is basal ganglia involvement with ion deposition. They can present with these extrapyramidal symptoms at this age. Then metabolic disorders, as already Prashant has mentioned, many metabolic disorders may present like this, like urea cycle defects, araginase deficiency. Myelopathy, spinal disorders, vitamin B12 deficiencies, biotin deficiencies, structural like syrinx. Rarely leukodystrophies like adrenoleukodystrophies may present with a diplegic-like presentation and later onset and worsen. And sometimes neurotransmitter disorders like dopa-responsive dystonia. So accordingly, he was investigated. His gait, still you can see without treatment, the way he's walking. Difficulty in initiation of the gait. So MRI brain was done, which was normal. Already one MRI was done. And then we repeated the MRI with spine, which was normal. So that most of the time cerebral palsy, normal MRI, we have to take it with a pinch of salt. Vitamin B12 was normal. His metabolic workup with TMS, amino acids, acetyl carnitine profile, and GCMS, urine organic acid profile was normal. His ammonia was normal. His EMG NCV showed no LMN weakness, but it is a UMN weakness, no evidence of any neuropathy. And then this was his previous, and this was his after 3 months of there is significant improvement you can see the way he's walking.
नाव सांग थोडंसं मागे जा थांबव मावशी एकच मिनिट.
So as you can appreciate, there is definitely improvement within 2-3 months. So how it is possible to have a case which is diagnosed as diplegic cerebral palsy by various doctors beforehand?
One second, would anybody like to guess what it is, this treatment that he's given them? Put it in the chat. Anybody like to guess? I've already seen one answer was arginase deficiency. A very good thought. Very, very good thought. It is a rare presentation. Biotin. Someone has written biotin. Anjali. Dopamine. Someone has put dopamine. Another one has put dopamine. Okay, so good thoughts. Very good thoughts. Umesh, carry on.
Yeah. So I'm glad that so many people are there and interacting and rightly judged. So he was started on a very low dose of dopa and gradually increased then. And he had this significant improvement. See the first video and the second video is
नाव
almost
सांग
similar.
रे तुझं. हात नको लावू, हाताचं सोडून चाल जा परत वीस म्हणत.
So he was diagnosed with this dopa responsive dystonia. His mutation came positive, GCH1 mutation, and it is pathogenic. Both parents were heterozygous. And this is a simple test. Nowadays, it's not that costly as compared to the previous era. And it is sometimes as equivalent of MRI cost, a good quality MRI cost. And it is worth to do in such cases. You can see the significant difference in the life of the child. So just to highlight that one of the cerebral palsy mimic is these various kind of neurotransmitter disorders. And one, as in office practice, one has to keep in mind that these conditions, I'm not going to describe them in detail here. This is the pathway which from this amino acids, we will have monoamine neurotransmitter like serotonin, dopa, norepinephrine, epinephrine, which is required in our body for the various functions. So if there is defect in these pathways, you will have various symptoms depending on this and result disorders. So one has to keep in mind in our office practice that these disorders can present in same like a cerebral palsy. And this is another child with dystonia, and then he was started on treatment with dopa and developed this kind of dyskinesias. So one has to keep in mind that their receptors, neurotransmitter receptors, never exposed to the dopamine. And that's why when you start, they may have hypersensitivity to dopa, and they may start having these dyskinesias, means hyperkinesias, excessive amounts of movement. You can see it, excessive amounts of movements. So this is again a clue that it might be a dopa responsive dystonia, and that's why we have to go very slowly. And depending on the type, sometimes we have to supply other drugs like serotonic like 5-hydroxytryptamine, folinic acids, and sometimes diet modifications to reduce this phenylalanine tryptophan from the diet. So these other supplements they may require. So this is something which is very, very, very rewarding condition. Like this another example, this girl, she was in second standard and then she stopped walking. And there was no, she was at home for 2-3 years. See this? And then after 3 months, the same girl. Absolutely normal. So this is a miracle drug which all dopa responsive dystonia, and this dopa tablet cost 1 rupees only, and we need not have to give full tablet also. So such a cheaper treatment. Only thing that in office practice we have to suspect. You can see the difference. The same girl. So almost like a normal child. So these are dopa responsive dystonia called as Segava. So cerebral palsy, in summary, that it is a static disorder with birth-related injury. So when there is no definitive birth-related injury, think about cerebral palsy mimics. Many metabolic non-progressive genetic disorders may present in that way and may mimic like a CP. So to summarize last 2-3 slides, when to investigate or suspect diagnosis of CP. No birth history. You have to take a proper history. Sometimes they will just say that the child did not cry, but ask if the child was feeding on the first day. If the child is feeding on the first day, it is very unlikely child had HIV. Then of course you have to take history for other days also, like hypoglycemia on 3rd, 4th day, any other event after that. So birth history is very important. If there is family history of other siblings affected, take it with a pinch of salt. Treatable causes always to 6, like this condition which I already thought. Clinical examination, there is no particular pattern like what in cerebral palsy we see as spastic cerebral palsy as diaplegia, hemiplegia, quadriplegia, or it may be a dyskinetic or kernicterus-like presentation, spastic dystonic. So if there is no particular pattern, like suppose you are seeing a spastic quadriplegic child, like this girl, almost like a quadriplegic, but preserved cognition, excellent cognition, it is unlikely to be a cerebral palsy. So in such cases, you think about possible cerebral palsy mimics or imaging. If you're seeing a severe cerebral palsy and absolutely normal MRI, good quality MRI, of course, then think about cerebral palsy mimics. And sometimes it is worth if you are worth to investigate if you are in doubt. And when to suspect neurotransmitter, already I have mentioned the normal birth history, diaplegic CP-like presentation, vaccine weaning is very important. Like this mother on asking gave history that in the morning the child used to be not good. But in the evening it worsens. So fluctuation of the weakness, predominant movement disorders, normal birth MRI, a normal MRI brain, and sometimes we do serum prolactin and serum phenylalanine as a markers, which are cheaper tests. And in every case, if you are suspecting it is not a cerebral palsy, diplegic cerebral palsy particularly, it's worth to try DOPA, which comes as a 100 plus 25 milligram tablet. Start at very low dose. Sometimes you have to give 1/10 or 1/8 of the tablet, and gradually you increase the doses and monitor them for at least few weeks to months to see the result. Thank you very much.
Thank you, Umesh. That was excellent. So I think we had lots of take-homes from this case. The red flags, because CP is such a common entity that very often in your busy practices, as you all just said, you see so much of CP that it just comes and goes through the clinic very fast. But the few things that should make you realize is, one is if you have no birth history, no antenatal or natal or postnatal history. If the child is delayed right here, if you see his milestones, the child was delayed from the start, but he got worse as time got by. So it wasn't like we were 100% normal. If we were 100% normal and he regressed, you would have stood up and said, oh, neuroregression. But that little bit of delayed from the start sort of made you think CP, and then once that chap came CP on the paper, it just keeps going every day CP. So think back and see family history, normal birth. I love the way you highlighted the role of the NICU stay. That is one question as a neurologist we always ask. Two things: the importance of the head circumference at birth, very important, and the second is the duration in the NICU stay, and whether the child was feeding at the time of discharge, and if feeding, was it bottle feed, was it vati spoon feed, was it breastfeeding. It gives us straight away an idea of the coordination of the oromotor cavity, indicating whether you have some damage coming from the brain. You get it? So if a child, even if he goes home after 1 week, but it says not breastfeeding, had to be given only vati chamchi because he could not suck well, makes you red flag go up. Something is wrong in this child, even if there was no perinatal history. So the days in the NICU and what was the feeding status when he was discharged in the NICU was very, very, very important. And then the last thing I think was the diurnal variation, which is very characteristic of DOPA responsive, that they are best in the morning, because when you wake up, dopamine gets secreted in your sleep. So when you wake up, your dopamine levels are high, so you function well. And as the day goes by, you get depleted of dopamine and you become tighter and tighter and tighter and tighter, and the characteristic features come by the end of the day. So if he sleeps in the afternoon, again he will be good in the evening, and then again he'll become tight by night. So the diurnal fluctuations. And I think the one take home that I would always say, if you have an unexplained cerebral palsy, whatever it is, you don't even know if it's a dystonic or a spastic or a quadri or a di, please try DOPA. Levodopa, okay, is what you need. Levodopa is what you give. 1 to 3 milligrams starting dose, and then if it is, you can increase it slowly. But always try, give a trial for 3 months, and if it doesn't work, take it off. If it works, then you investigate and you see. It's the cheapest way to check whether the child is one of the neurotransmitters. You don't even do the genetics, you don't do the CSF, nothing. You first just try the DOPA and see if it works. Superb. Thank you, Umesh.
Thank you, madam. Thank you.
Thank you, ma'am, for the very important take-home messages. Thank you, Umesh sir, for presenting an excellent and very rare case. Thank you very much. With that, we move on to our third mentee, which is from Dr. Madhuri Shaike, ma'am, from Aurangabad. She is a consultant in pediatric neurology at Icon Center for Child Neurodevelopment and Sigma Hospital, Aurangabad. Ma'am is also president for iProgress Foundation for Special Children, Aurangabad. Ma'am is associated professor at Government Medical College in Department of Pediatrics, Aurangabad. She has been invited as faculty in various conferences at state and national level too. Welcome to ma'am. Over to you, ma'am. Thank you very much.
Good evening, everybody. Thank you, Dr. Gangolia sir and Dr. Amol Pawar sir, for arranging this wonderful mentor-mentee meeting. And I'm always thankful to Dr. Anayata ma'am for everything she's guided us throughout. So I'll share my screen.
Yes, madam. Yes.
Yeah. Can you see my screen now?
Yes, now we can.
So this is today's discussion. This child my voice is clear. Am I audible?
Yes, ma'am, your voice is quite clear. Rest of the audience, kindly mute yourself.
This child is 14-month-old boy.
Yes, ma'am, done.
Yes, this boy is 14-month-old boy who is second born from consanguineous marriage. There is no significant perinatal history. His birth weight was adequate, 2.5 kg. He had presented with irritability since 8 days before the presentation, and there were some abnormal movements. So these were the moments for which this child had come. These are the episodes of tonic posturing which used to last for few seconds, and he used to get multiple episodes per day. So once the cluster of similar jerks were noted and with increasing irritability, he was admitted in the hospital. So on inquiry further history, we have, there is no history of altered sensorium. The child used to be irritable throughout the day. In the OPD, I have taken this video. The child was irritable throughout the examination. There's no history of loss of consciousness, no history of fever, no history of trauma, or any history of significant medications taken prior. There's history of fever with rash 2 months back, but it was self-limited and child had not received any significant treatment for that fever. There's no family history. His development on inquiry was delayed. At 14 months, the child was sitting, and the speech he had only a few bisyllables. And on examination, he had this. The child was very restless, hyperkinetic, and there were some ataxic movement. Eye contact was good. Child was recognizing parents, so there was no altered sensorium or encephalopathy-like picture. On CNS examination, he had adequate head size for his age. He was mildly hypotonic with present reflexes, and there were no other focal neurological deficit or any neurocutaneous markers or dysmorphism. So we have a 14-month-old child who had normal birth history, no perinatal event, but there was some developmental delay, and he had presented with these episodes of tonic posturing lasting for few seconds with increasing irritability. So here our differential scape where first whether we are dealing with some neurometabolic disorder considering his global delay before the onset of new onset irritability, and whether these are epileptic spasms. And second differential was scaped was immune mediated disorder considering there is a history of fever with rash 2 months back, and there are some vague presentation which is not fitting into one single etiology. So the basic, yes.
Madhvi, if I interrupted you here.
Yes, ma'am. Yes, ma'am.
The characteristic feature that you are showing us is this marked irritability.
Yes.
When you see marked irritability like this, what are the conditions that come to your mind?
At this age, like child is 14-month-old and sudden new onset irritability, the first thing would come in my mind is whether we are dealing with opsoclonus myoclonus syndrome because irritability and there was some kind of ataxia, but child didn't have any opsoclonus kind of thing. Second is whether we are dealing with some neuroregression like disorder like Krabbe's disease. And third would be some immune mediated mechanism which is happening, like onset of autoimmune encephalitis, maybe.
Okay, excellent.
Yeah, when we did the basic metabolic workup, which was normal calcium, serum electrolyte, SGPT, and as that was the COVID period, so COVID PCR, even the COVID antibodies done later on were normal. CSF was done in view of irritability and which showed normal CSF features. CSF glucose was 56 and the corresponding random blood sugar was also normal. MRI brain was normal, which was done along with MR spectro because our suspicion clinically was neurometabolic disorder. The EEG which was done bedside did show some focal IEDs which were circled on the EEG, but it was not giving any clear-cut clue towards diagnosis. So again, after the investigation, our differentials were neurometabolic disorder, whether we are dealing with some post-infectious immune-mediated movement disorder or onset of immune-mediated encephalitis. And third was added because there was normal MRI and no significant abnormality was found on the blood investigation. So genetic epilepsy. The TMS GCMS, which was same here, came out to be normal. This child, when got admitted, was treated with levetiracetam and benzodiazepine. But discharge on oral valproic acid, clobazam, and a trial of biotin pyridoxine was given. Though the TMS GCMS was normal, we were not sure what exactly we are dealing with. So the levetiracetam was omitted at discharge in view of irritability in this child. So the same child presented after 1 week with typical epileptic spasms. He used to get many such spasms, and there was regression of speech, which was there. Few bisyllables, the child regressed that speech also. The EEG, which was repeated after few days, showed multifocal slow background with generalized epileptiform discharges, which is followed by a brief suppression of background activity. So here we could label this child as a case of West syndrome, and we added oral steroids. But a child didn't respond to oral steroids. He continued to be very irritable, so admitted, and ACTH was given. After ACTH, the frequency of jerks decreased to some extent, but child remained irritable, and he didn't get milestone. So after ACTH, steroid, and antiepileptics, we have a case which is epilepsy with regression, West syndrome, and which has progressive course. So it is now almost a month after onset of first symptom. Yes, ma'am.
So Madhuri, on this, on what basis did you diagnose him as West syndrome?
The child had presented with typical epileptic spasms, as we have seen in the video, the flexor spasm. His EEG was sent to hips arrhythmia, the burst suppression kind of thing. And also clinically, he has shown some regression. Though child was delayed, there is some regression to add it to that because he lost sitting and the speech also regressed.
So do you think, do you need all these criteria to diagnose West? And do you need all these three to start the ACTH or?
No, ma'am. At least two of these two criteria. Because the first presentation we did think of epileptic spasm, but EEG was not supportive, and neither the history of regression we are getting apart from irritability. So after a week, when EEG got worsened, we tried ACTH.
I agree. I would have done the same, but honestly, that irritability was very significant in a form, means the onset of.
We should have considered that as encephalopathy.
You could have considered it as an encephalopathy. It's a different stage. You see, the irritability, it's known that just change in behavior is considered enough to be an encephalopathy. The EEG was very non-specific, and the spasms were also very questionable. So I agree with you that because ACTH is not a small drug, you can't put it on without justification. But the thought process is there. That's important, that either 2 out of the 3 is there and you quickly start ACTH as soon as possible. Is ACTH the best drug, or could you have tried something else?
The oral steroid and ACTH, the ACTH performs better out of these two.
So that's right. ACTH and oral steroids would be your first choice.
The ACTH will be definitely first choice as compared to if we see the response.
Yeah.
The availability and cost is issue.
Okay, carry on.
Yes. This again got admitted for irritability jerks. This time he was given intravenous antiepileptic drugs. Jerks decreased, child became stable. Discharge again after 1 month, came back with similar kind of irritability, and this time he had more of dyskinesia rather than epileptic spasms. We tried again a course of steroid, but there was no response. Vigabatrin was also tried orally, but there was again no response. So, and drug-resistant epilepsy with the encephalopathy, epileptic encephalopathy, we sent genetic because the third differential was genetic epilepsy. And meanwhile, while we were waiting for the reports of genetic testing, we added lacosamide and there was some response, but child continued to have irritability. And retrospectively, when we saw the child, when he was better, we noticed that whenever we were giving the child lacosamide and phenytoin, child was performing better as compared to other drugs, which the child was on like valproic acid, clobazam, or topiramate.
So Madhvi, before we go on, I'm just looking at the chat. People have put in little diagnoses that they think might have been. Can you
Yes.
tell me why you didn't think of these diagnoses? Ataxia telangiectasia.
Okay, ataxia telangiectasia, usually the child presents with imbalance, not with irritability. And the regression is not so acute as we have seen in this child, because the child who has regressed within a month. And third thing is the EEG will not be so abnormal in ataxia. Most of the time that telangiectasia part comes later on, because at 14 months we may not see the telangiectasia in the eyes, but the child may not present with such kind of severe regression.
Plus the age is a bit young. 14
Yes,
months for
14 months.
ataxia telangiectasia is a bit young. The next person has said Landau-Kleffner syndrome. Why not Landau-Kleffner?
Again, Landau-Kleffner syndrome, the LKS has more of the epileptic aphasia. The children are not encephalopathic. Also, they do not have the epileptic spasms which this child has, and again, the age of onset. That's usually the childhood onset disorder.
So it's a
So
speech
these
regression. Speech
yes,
regression
speech
with an
regression.
EEG which shows very frequent temporal discharges, not spasms, which is there. The next person has said SSPE.
Yes, SSP
14
with
months. 14
yes.
months.
Yeah, SSP, we did think at some point where we were getting that kind of EEG, multiple jerks per day, and there is history of fever with rash 2 months back. Again, the gap between the rash and the onset of the jerks is very less. So it rather than SSP, it could be just in measles, encephalitis, but the child wouldn't have been normal in between. And this we ruled out. We were on the verge of doing CSF, but after the third admission, child responded significantly. The jerks were decreased almost completely. So that is one point where we don't get such kind of picture in SSP, like the child gets jerks for significant jerks and then stops suddenly.
And the last one is someone has said NCL.
Yeah, NCL, again, the same thing. The onset and the progression is very fast in this case. NCL, even if it is an infantile onset, is not so fast progressive disorder. Also, they rarely come with such kind of epileptic spasms appearing at 14 months of age.
And the last thing is someone has said, can you have treated with IVIG, the West syndrome?
The IVIG, particularly in West syndrome, is not much, the studies do not support much evidence of IVIG. The ACTH has more use because it is through the corticotropin releasing hormone mechanism. The IVIG will not be helpful in that mechanism, particularly to suppress the spasms.
Okay, carry on. Very good. Just carry on.
Again, when the report came, it showed us the SCN2A gene encephalopathy, which is epileptic encephalopathy early onset. And these mutations are well controlled by high therapeutic doses of sodium channel blocker, particularly phenytoin, lacosamide drug. So that was the reason the child used to perform better on this drug. When we started phenytoin in little higher doses, 5 to 6 milligram per kg and increased to 7, they developed the seizure burden reduced, the EEG, the jerks, the bursts were very much less on the repeated EEGs, but the development remained delayed 3 months after the treatment. So when we go to the literature, SCN2A encephalopathy, this is voltage-gated sodium channel genes, which are the commonest cause of genetic epilepsies. The SCN2A is second common in those categories. It has a large spectrum of phenotype. ranging from self-limited epilepsy to epileptic encephalopathy. Our child fell into the group of childhood onset SCN2A encephalopathy. They can have multiple types of focal seizures, and usually the infantile onset, that is early onset children, they have the infantile spasms, tonic seizures. Drug of choice are sodium channel blockers, and it works particularly in the first 3 months of life. So take home message is consider genetic epilepsy early in the course if we are dealing with pharmacoresistant epilepsies with developmental delay and normal neuroimaging or investigations. Whole exome sequencing should be our the choice of taste. Use of sodium channel blockers, particularly in the first 3 months of life with drug-resistant epilepsy, particularly if the epilepsy onset is very early, in the second week, third week, and if the child continues to get multiple types of focal seizure, the sodium channel blocker should be, the trial of sodium channel blocker should be given in these children, because as ma'am has pointed out initially, that the genetic reports take time, and we can't just let the child to have so much of seizure burden. So that is the major take-home message we would like to give you today, that any drug-resistant epilepsy in first 3 months of life, we should be giving a sodium channel blocker.
Thank you. Thank you,
Thank
Madhu.
you.
Thank you. So here, I think there are lots of messages I would like to give. One is we had normal birth and development. But if you take the history carefully, you had a delayed development to start with, then the epilepsy came. So it's very easy for us to say, akdi ke karan se uski development has gone back. Okay, but very often if you look carefully, if the development is delayed prior to the onset of epilepsy, it is a clue that you are looking at a developmental epileptic encephalopathy and not epilepsy-induced regression. Okay, so a good history and a good milestone history will define whether this is epilepsy-induced regression or whether this is something where epilepsy is part of a bigger picture in which development is also there. The next thing is, when you see a movement disorder and epilepsy, think genetic. Okay, so you'll have dyskinesias, dystonias, lots of abnormal movements which cannot be explained. MRI looks absolutely normal. Basal ganglia is clean. Why has this child got movement disorder? There's no explanation. There's no explanation for the epilepsy. There's usually no family history because these are all de novo mutations. They're just mutations. They don't come from families. They are not inherited. But they come with delayed development, normal birth, normal MRI, normal EEG when they start. So you saw her first EEG was almost normal. You had to sort of look hard to find something abnormal there. So normal birth, normal MRI, normal EEG, slightly delayed child, then comes the seizure onset, and then they don't respond to any medication. And then they slowly start going down, 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 down. Cognition goes down, seizures become very bad, MRI starts becoming abnormal, EEG starts becoming abnormal, and the picture is very sad. So the take home here is that there are certain drugs, sodium channel drugs. Which are our sodium channel drugs? Carbamazepine, phenytoin, oxcarbazepine, lacosamide. These may be the main 4 sodium channel drugs that you need to remember. And these sodium channel, you would never use a sodium channel drug in the past in a 3-month baby. Have you ever put oxcarbazepine on a 1-month baby? It's not in our books. It's not on the charts. It's not part of your treatment protocol. But do remember, if you do not respond to treatment, if you have seizures less than 3 months of age which do not respond to regular medication, please start oxcarbazepine immediately. If you start the correct drug within 72 hours of the seizure, this child's development can be normal. You start treatment after a few days, after a few weeks. You will make a difference, but there will be some cognitive decline and some delay which is there. So this is a relatively new space. After 6 months of age, ideally, sodium channel drugs have to be used very carefully because they can make certain epilepsies worse. So let's just remember, if you're less than 3 months of age, you have a normal birth history, normal MRI, normal family history, normal everything, and you have intractable seizures of no cause, metabolic negative, please try either phenytoin, carbamazepine, oxcarbazepine, and see if it makes a difference to the child. So I think at the end of these 3 cases, we tried to highlight treatable conditions that you cannot afford to miss from now on. Thiamine, add the thiamine to the biotin and the pyridoxine. You all do biotin and pyridoxine. Everyone has learnt that now. So biotin, pyridoxine, start, add thiamine. Regression, encephalopathy with or without consanguinity in a young infant, they usually present in the first year of life. Please add thiamine to see if it makes a world of a difference. In Umesh's case, the role of dopamine, a CP which is unexplained, normal MRI, normal history. Just give a trial of dopamine. It doesn't work in 3 months, take it off. If it works, we look and we investigate accordingly. And the last one is in intractable epilepsies in young children, particularly less than 3 months. Please try oxcarbazepine, carbamazepine, phenytoin as a drug of choice if you cannot control it with the regular anti-epileptic medication. So I think those were the 3 messages we wanted to give you, and 3 common conditions that you might see, and I'm sure you all will see it in practice soon. And even if 1 or 2, don't wait for the genetic report. You see, all of them were proved on genetics, so these are all precision medicine at the end of the day. But in the absence of the genetic report, please try. Thank you.
Thank you, ma'am.
Thank you very much, ma'am. Thank you, Madhvi ma'am, for the excellent case presentation. And congratulations for the wonderful question answer session. Thank you, Anaita ma'am. With that, I hand over mic to Dr. Sonali ma'am for the further program. Thank you, ma'am.
Thank you, Reena madam. Really a wonderful session we had today with full presentee, and all are waiting here totally to hear all our mentee and mentor as well. So I would like to thank for this wonderful session our President Dr. Hemant Gangolia sir, our Secretary Dr. Amol Pawar sir, our convener Dr. Jay Bhandarkar sir. Such a wonderful session they had brought to us so that we are here today. And I am special thank for our gorgeous mentor, our guest, Dr. Anaita Hegde madam, who enlightened us with very well to the treatable neurological cases. I would like to thank our esteemed speakers, Dr. Utage sir, Dr. Kalane sir, and Dr. Madhvi madam for such a wonderful case discussions. I would like to thank our digital media doctors, Dr. Vishal Raut and Dr. Neha Singh, because they work so hard for the flyers, and Dr. Pallavi madam of the DIP. I would like to thank Dr. Reena madam as a co-host. Thank you, dear audiences, for wonderful listening. Thank you very much.
Thank you.
Thank you, everyone.
Thank you.
Thank you. Thank you, everyone.